In this session we're going to look at the lower leg, which includes the area between the knee and the foot. We're going to look at three specific items. First of all at the interosseous membrane, then at the fibula and a way of deciding which side it comes from, and thirdly we're going to look at the relationships of the tibia and fibula. So let's start looking at the interosseous membranes. We've already looked at these in reference to the radius and ulna, but now let's look specifically at the left tibia and fibula. Because the interosseous membrane is basically fibrous tissue between two bones, it is therefore the equivalent of a fibrous joint. As with the interosseous membrane between the radius and ulna, there is a gap at the upper end of the interosseous membrane for allowing vessels to get through into the anterior part of the leg. But more important is the direction of the fibres in the interosseous membrane that allow the transmission of forces from the tibia to be shared with the fibula. So you'll see from this image that the fibres pass downwards and laterally, and this will allow immediate sharing of the forces as it's applied through the talus to the lower end of the tibia. Now let's pass on to a method of deciding which side of the body a particular fibula fits with. The general description of the fibula will be that it has a head at its upper end. This is rather bulbous, and there is a facet, of course, the superior surface for the superior tibiofibular joint. At its lower end, it's more arrow-shaped, and it makes the lateral malleolus. There is a facet on its medial side, which is articulating with the tibia, and this is the inferior tibiofibular joint. The fibrous tissue that binds these two bones together inferiorly is the continuation downwards of the interosseous membrane. So the inferior tibiofibular joint is a fibrous joint, whereas the superior one is a synovial joint and does allow a tiny bit of movement when the foot is dorsiflexed. This is because of the shape of the sides of the talus and the ability of the lower end of the fibula to follow the gentle curves of this bone, and this will give a very small degree of twisting force within the fibula and the necessity of a small amount of movement at the superior tibiofibular joint. Now, to decide which way a fibula fits on the body, we hold the lower end of the fibula with the pulp of one's thumb sitting comfortably in the pit, which is on the posterior aspect. If it fits easily, then the fibula is the same side as your hand. In this case that we're showing here, it is a right fibula and is being held comfortably by the right hand. If it isn't a comfortable fit, then it belongs to the opposite side of the body. Now this rather full image shows some really important aspects. What is quite clear is that the lateral malleolus is made up of the lower end of the fibula, and the medial malleolus made up by the medial side of the tibia. The order of the structures that pass between these two malleoli on the anterior aspect of the ankle are really important, and we'll give them here in order as A is the tibialis anterior tendon, B is the extensor hallucis longus tendon, C is the combination of the anterior tibial artery and vein, and then on the lateral side of those is the deep fibular nerve. The next set of tendons belong to the extensor digitorum longus, and then finally there is the tendon of fibularis tertius, which of course is not always present. We'll look at other tendons associated with the ankle in a separate session. But we do have a mnemonic for those tendons that we've just listed, and it is Timothy has a very nasty disease, fever. or it could be a Timothy has a very nasty diseased foot, if you prefer that. So now let's turn our attention to the upper end of the tibia and fibula, and the key aspects that I wish to emphasize are that the common fibular nerve passes around from posteriorly to anteriorly around the neck of the fibula. It is, of course, here that it can be damaged rather easily. It soon divides into its superficial and deep branches, which we've described in detail elsewhere. Note that the anterior tibial artery is allowed to pass through between the bones above the superior aspect of the interosseous membrane, and it is important to appreciate that only arteries may pass between bones like this, but nerves always go round the outside. Other aspects to note are the lateral collateral ligament attaching to the upper end of the fibula, and the biceps tendon also alongside it. The iliotibial tract, such an important part of locking of the knee, is on the upper lateral side of the tibia. Below the epiphyseal line are the medial and lateral patella retinacular, and we remind ourselves that the retinacular fibers on the medial side are much stronger than the ones on the lateral side in order to hold the patella in place. Semimembranosus attaches up near the upper aspect of the tibia on the medial side, and then below are the tendons of sartorius, gracilis, and semitendinosus. In fact, the order of these tendons from inferior to superior can be remembered by the mnemonic "Say grace before T mum." That is sartorius, gracilis, semitendinosus, and then finally semimembranosus much higher up. In the midline is the attachment of the ligamentum patelli, and then just above that a rather smooth area of bone, which is where the deep infrapatellar bursa overlies it. And then finally we have the medial collateral ligament on the upper medial aspect of the tibia. And with that description of the upper tibia and fibula, we end this session.